next work session is the 988 initiative update. Ms. Freed.
Good afternoon, Mr. Chairman, members of the board, Dr. Casey. I'm pleased to be here for a few minutes to give you an update on the federal 988 initiative as well as the state Marcus Alert legislation that both Chesterfield is working to implement both of these currently this year. Just to start with 988, this is a national awareness campaign. It actually started in 2005 with a national suicide prevention hotline number. That number is still active. If someone calls that number, they'll reach the hotline. But the movement starting in 2019 with the Federal Communications Commission, as well as the Department of Veterans Administration and SAMHSA, which is the Substance Abuse Mental Health Services Administration, was to start moving towards a 3-digit number to make it easier for people to reach folks. And so that's how 988 started being developed. It was actually signed into law, I think, in 2020, and of course, implementation started this past July. So individuals can call 988 and receive a direct connection to compassionate, accessible care and support. Because the Veterans Administration was involved as well, you can call 9881 if you're a veteran and get directly linked to the Veterans Crisis Hotline, but it doesn't matter if somebody just calls 988, they're going to receive the services that they need. It's a national network of about 200 crisis call centers across the nation, and so anybody that calls 988 is going to get connected to one of those service lines. I know there's been some concerns about the lack of geolocation for 988 that exists for 911. But they're going to get served right at the number that they call. There's not going to be a transfer. You're actually not allowed to transfer crisis calls. And so they'll be served, but they'll be gathering as much information just to determine that there doesn't need to be a 911 direct linkage. But what they're finding is that the majority of the calls do not require a physical response. They're able to help those individuals right on that call. Speak to it just a little bit about Virginia's. As I said, there's 200 national centers, call centers across the nation. Some of the calls are operated by the states, and some are operated by regional call centers. And Virginia chose to operate according to regional call centers. The good news about that, and these regions are set according to the Community Services Board region. So we are in Region 4, which is with Henrico District 19. Crossroads, Hanover, Goochland, Powhatan. I think those were the main ones in our region, and Crossroads. So if anybody calls 988, you're actually, the call center that operates our regional call center is PRS Crisis Link, which is really the same company that operates the national suicide hotline. So Virginia chose, we could do it by region. All of the regions in Virginia are using the same company, with the exception of Southwest Virginia. They're using Frontier Health, but they each back each other up. So it doesn't matter which region you're in. If you make a call, you're going to be served by either PRS Crisis Link or Frontier Health. These call centers are accredited. They're required to be accredited by at least one organization. PRS Crisis Link is accredited by 2, which is the International Council of Helplines, as well as the Council for Suicidality. So they're well-versed in operating the call center. They must adhere to the SAMHSA, Service Administration, mental health policies and procedures. And really, their focus is not just on imminent risk. It's really a focus on capacity for safety to remain in the community. And so what they do is, a lot of their calls are escalated maybe at the start, but their job is to de-escalate those calls. They do risk assessments that address many factors aside from just suicidality. A lot of times individuals are distressed because of their housing situation, and so they assess them for a lot of different aspects that could be creating their challenges. The call could end up with a follow-up call within 24 hours. It could end up in some type of care navigation, linking them to, like our department that provides same-day access and can start helping them receive services, or there could be some type of mobile response due to the capacity of, or their lack of capacity capacity where they need to be served in the community. And of course, the call centers also have clinical staff that are behind the scenes. They're constantly reviewing the services and the outcomes of these calls to ensure that the services are provided the best that they can. I think what's important to remember, though, is that 988, and when I start talking about the state's legislation around Marcus Alert Response, those are two different initiatives. So regardless of the state developing legislation, 988 being federal was going to occur anyway. So whether someone participates, and I'll get to the Marcus Alert in a second, but if a locality doesn't have to participate in the Marcus Alert legislation, they're still going to be receiving 988 services in their locality. So moving to the state legislation, this was enacted in 2020, and basically what this is requiring is that behavioral health, law enforcement agencies, and 911 communication centers communicate and work together to provide a behavioral health response to a behavioral health situation. So this legislation requires all localities in the state of Virginia to implement within 2028 unless you are a locality that is less than 40,000 in population. And so those are not required to implement. They can, but they're not required under this legislation. Again, this rollout of this legislation is also by Community Services Board region, and it's by population within those regions to determine which locality will go in what order. So Richmond, even though they're less of a population than Chesterfield, they were the first to implement, mainly because the situation that led to this legislation actually occurred in Richmond. And as they were working to determine what responses needed to be appropriate in the future, they were sitting at the table with all of the folks when the legislation was developed, and so they went first to implement, and they actually implemented last year. Chesterfield, now being edged a little bit higher in population than Henrico, is slated to go this year, and we have had a team that's been working very hard throughout the year to get this in place. There's a few protocols that, there's three protocols that are required to be implemented. And so the protocol one, this is really talking about if somebody calls 911, and I'll go into some actual examples in a few minutes, but if it's not a response where police are needed, then if it's appropriate to divert the call to 988, then we just need to have a protocol that shows that we're doing that where it's appropriate. It is very clear that if anybody should call 911 requesting a police response, they're going to get that. No calls are going to be diverted to 988 if the caller specifically asks for 911. So I think it's very important to note that. The second protocol, if there are calls that go directly to 988, they may bypass our 911 to begin with. And if crisis teams or other folks are deployed because it doesn't seem like police is needed for those calls, but yet police, they get out there, the crisis team gets out there, they feel uncomfortable, there might be a weapon, and that they feel like police need to be on scene, then Protocol 2 just discusses how police will be called and will agree to provide appropriate backup to those crisis stabilization units. Protocol 3, that's really looking at co-response, where our crisis team will go out in with police as a co-response team to situations. And then the last part of the protocols that we need to develop is a stakeholders group, which we've already done that. Last year, as I said, we have a county team that's been working for over a year. We had our stakeholders meeting back in November. We're going to have ongoing meetings, but so far, it was a wasn't well attended because we opened it up to maybe 1,500 people and we had a much smaller group. But we had folks that attended and they were willing to be part of our stakeholders group, and so we feel very good about that, and we'll update them along the way. I do want to say, while I'm talking about our county task force, I just have to say a special shout out to Major Brad Badgerow, Tommy Tucker from the Emergency Communications Center, Andrew Fullwider from the County Attorney's Office. They have been working behind the scenes with me now for quite a while to really start getting our protocols in place. And we're in pretty good shape with that. Speaking just a little bit about, I know this is a little bit hard to see, but the green, yellow, so forth. Green represents level 1 calls, yellow represents level 2. I'll focus on those first. Those are really calls that do not involve suicidality, intent to harm others. There don't appear to be weapons in the house or anything like that. These are folks that may just need to talk to somebody, maybe sort of like a warm line situation. And so those are the types of calls that, we're hoping can be handled by the 988 call center. Again, the majority of those types of calls do not require a physical response, and so there's no sense in tying up police resources to responding to those types of calls when police traditionally would transfer those calls to our crisis line anyway. But again, if any of those situations occur and police need to respond, they will respond. It's not a method to keep police out. It's just, are they needed at all when their resources could be used in other ways? Then when you start getting into level 3 calls, it's getting more urgent. There is suicidality, there's homicidality perhaps, and then there may be weapons involved. And so at that time, then police absolutely need to be on scene, and where we can provide a co-response and have a behavioral health provider also participate in those response to, again, try to de-escalate, prevent a hospitalization situation, and maybe get some services in the community to stabilize the individual, then that's really the goal for the level 3 responses. And then with level 4, those are the most critical. Again, we may have our hostage negotiation teams out there. We may have, other types of higher level co-response, but definitely police and fire and EMS likely are on the scene for those types of calls. I do want to note that the 988 call center can deploy some crisis stabilization units. Those are regional teams that are being deployed from the state. So 988 does not have the ability to to deploy any co-response teams in Chesterfield. That is all. They can only deploy regional resources. And then the same way, when 911, if they evoke, they're the only ones that can call out the co-response teams between police and our crisis department. 988 can't call and say, hey, we want co-response, we want you all to go out and handle these calls. That's how we sort of dispatch that separately. So the lower level calls can be dispatched by 988. They'll send out crisis regional providers, but the higher level, really critical calls, those are all being dispatched by 911, and those would involve our crisis co-response team for those types of calls. So just to give you the quick timeline, again, Chesterfield, we are due to implement as of July 1, and so our protocols are due to be sent to the state by the end of this month. Like I said, we're well underway, ready to send those in. There is $600,000 of ongoing funding that the Department of Behavioral Health is providing this first year for implementation, prior to implementing and for FY23, and then ongoing every year after. And so there is a consent agenda item this evening to allow us to accept the funding so that, for these planning and implementation purposes. Ran through that quickly, but that's sort of what we're in the process of doing. So are there any questions?
First over here, Mr. Engel, then Mr. Winston.
Thank you, Mr. Chair. So, a couple things. One, it sounds like, with the exception of maybe the level 2, where they might send somebody out, because level 1 would be more of a call, everything is pretty much running the way it was previous to this. And if they call 988 and it's actually a 911 call, how does 988 send that over to 911?
So 988 will actually gather as much information as they can right then, and then they're going to dispatch 911 and then get the two connected. They'll be letting 911 know where that individual is located and then dispatch it that way. They won't transfer the call to 911.
And if somebody calls 988 because they are on drugs or drunk, is that considered a mental health issue, or is that considered a some other type of issue?
It could be both. It just depends, because we have a lot of co-occurring disorders, and so they would triage that call just the same way. They would really be looking to see what is the root of the issues. In those cases, they would probably be reaching out to the local community services board so that we can start trying to get them in that same day, or depending on what the situation is, they may need 911 to take the individual to ensure that they're medically stable before we can do further services.
Thank you.
question for you. What is the expected volume for calls here? Are other states reporting that this is a large call volume, small call volume? What are we to expect?
There are lots of calls that come to 988. I was actually surprised as we were looking at this being implemented. So, the first year in 2005, over 46,000 calls went to the National Prevention Suicide Hotline. So there's lots of calls that come to them that don't actually come to our department. We receive, on average, about 1,000 calls a month. So now a lot of those end up are TDO type responses, and that would fall in this triage about a level 3 to a level 4. So, that's why co-response is ideal for us to be doing that with the police, because right now when police goes out on a call, the first thing they do is call us. We work the case together, and then a lot of times we do the evaluation because crisis teams are the only ones that can do the pre-screening evaluations. And so if it's that high level of a call anyway, the likelihood is higher that it's going to be maybe a situation where somebody needs to be hospitalized, and so therefore it's best for us to be out there to do that. So I really think that our calls will drop. We'll see. I don't think our calls will drop for the TDOs that we do, and we do about 35. Our average was 35 or 40 a month. I will say in January we did over 65, so that has increased. We are seeing a real increase in concerns, mental health concerns. So I think our TDO calls will level off. Will remain the same or increase. So we won't see the change in the need for us to respond there. But we also have a full call center in our department where folks are answering the telephone all day long. And so those calls will likely get less and less once 988 gets more implemented throughout Virginia. So.
Thank you.
Miller.
Thank you, Mr. Chair. Kelly, a couple of questions. We've known each other for over 20 years. We've worked together at the CSB for 13. I'm curious to know, when the 988 comes in, is it coming in directly to our crisis, or is it going to be coming to a more of a central?
It won't come to our crisis team at all. It's a central regional call center. So they may defer calls to us when it comes to triaging the calls out, depending on what the individuals need. Likely won't be sent to, it could be sent to our crisis department. It may come to our same-day access, or it may get sent to police, and then we get involved that way. But we're not the call center for the region. It's PRS. It's a contract company. It's the same company that runs the National Suicide Prevention Hotline.
I'm just trying to understand the mechanics. So if it does come to you, for instance, and just as you were describing for January, it's been
Right.
a more difficult, challenging month. So I have a couple questions just as far as staffing. I know I have someone who has received those phone calls, and if I get that and then all of a sudden, okay, I need to dispatch 911, I need someone else to be able to say, hey, I need to call 911.
Right.
So that I'm able to continue to be with that individual, but at the same time, someone's on the way.
Right.
So I'm curious to know, how are you doing with the staffing? Is there any way we can support you in that? Because if you could have 4 or 5 calls at the same time,
Right.
then it can get
Our goal right now, as we're planning this out, is to plan 2 co-response teams operating out of in cooperation with our department and the police. And so at this point, we are not making a recommendation to add more staff because right now, our staff are handling those same calls. They're just handling them in the office versus actually going out. It would be a rare day for us to have 4 or 5 at the same time. It's not unusual for us to have more than 1 TDO a day, but to have a bunch going on at the same time, that would be really unusual. But we have backup staff in our department who can assist and take care of those calls. The crisis stabilization units that are going to go out, they're going out based on regional resources, not our department. So those are actually additional resources that are available to each of the CSBs in the region, which is why we do not feel like we need to add staff at this point. They've added capacity to this system versus all the capacity coming from the localities.
I mean, that's a 24/7 gig for those folks
Yes,
that
it
are
is.
going out.
We're monitoring the peak times. We're basing that after Richmond. And so really and truly, the hottest times for these types of calls are from 2 o'clock in the afternoon until midnight. So, and it's usually Tuesday through Friday, believe it or not. Weekends are not what you would think they are, and Mondays aren't. It's usually Tuesday through Friday. So that's really the hours that we're starting with operating the co-response teams. But we have to remember, whether these co-response teams are going or not, our crisis team still is staffed 24/7, 7 days a week. So they're the ones that would be taking any calls that would happen outside of these peak hours that I just mentioned.
In connected with that, one of the things in your presentation was how important it is to break down those silos.
Yes.
And that was the problem or the challenges that Richmond was having.
Mm-hmm.
And I've never seen that at Chesterfield. We're always talking and communicating with each other.
Yeah. We have a strong support system here. I mean, with crisis police, I mean, it's a daily, and fire and EMS, I mean, we are really intertwined in so many different ways, and in all of our services, not just with crisis. So
And
you're right.
And I would make that argument that has a lot to do with you.
Well, I don't know about
And I know
that,
how
but-
humble you are,
Thank you.
but how good you are at being able to communicate. So, you have folks that are out at the jails, you have put folks out into the different silos to continue to improve and enhance the communication. So it's just a credit to you and all that you're doing.
Thank
So
you.
thank you.
Thanks.
Mr. Chairman.
Mr. Holland.
If I may, I just want to say thank you. I want to join my colleague in thanking you for the outstanding work that you have done and are doing in this area. I have one question in regards to the 988 call. There are no you said it's a regional call, but there are no regional resources sent out. How does that work then? If you call a 988 call and there's no resources sent out, are there resources sent out?
There are.
There
So,
are.
so 988 will get the call.
Okay.
They'll triage, or they'll, assess that call. If
Okay.
they find that an individual is in need of somebody helping them in the community, there are regional crisis mobilization units that can
Okay.
be dispatched. They're called Crest and Reach. They have been in existence now for our region for probably about 2 years. They are in the process of expanding those services because they need to in order to accommodate more and more localities that go live with this initiative. So they are out there. Actually, you have to respond within a certain amount of time, and so they're trying to locate their regional resources out into the various localities, and we actually have 2 staff that are using space in our department so that if a situation comes up in Chesterfield or District 19, Colonial Heights, something like that now, then they're close enough that they can get to that call as soon as possible and not be driving from Richmond, Hanover, or something like that to get here.
Thank you.
So yes, those
Excellent.
resources are available.
Thank
And those are the ones that I was saying can only be deployed by the 988 mobile call center. I mean, not mobile, but call center, because they're kind of controlling those resources, and then we would be controlling our local resources, which is why 911 here is the only ones that can deploy the co-response teams, which would be Chesterfield Crisis and Police, because we don't want the call center deploying our staff, to other localities. That could get really
Yes.
tricky.
Yeah.
So 988 controls the regional crisis stabilization units, and our 911 controls any co-response between our police and Chesterfield crisis staff, if that
Yes.
makes it
Thank
clear.
you so very much for
Okay.
clarifying for me. Thank you.
Mr. Chair.
Mr. Engel.
So green would probably be handled on the phone, most likely.
Hopefully, yes,
Yellow would probably be the regional team.
yes.
Then, I know red is the last one. Is it
Orange.
Orange. So orange would be probably a co-response between the police and possibly our team.
Chesterfield Crisis.
Probably our team.
Yes,
And then red would also be handled by the police mostly, but also our team could be responding to help as it's brought under control. Is that
yes,
correct?
yes.
Thank you.
Mr. Casey.
Can I just have one more thing, Mr. Chairman? Mr. Engel, I just wanted to mention that, in a call like that, it's not necessarily, it's very dynamic. So it could start out at one level, and it is possible to be able to talk the person down, or it can be where so that is the professionalism of your staff, it's the professionalism of being able, and the experience to be able to identify, okay, where are we going with this? So that it can be triaged, but it's through the process as to what makes sense. I just wanted to speak to that. That's what makes the CSB so fantastic at what they do.
Just to respond back, and Ms. Freed could be more specific to the straightforward question Dr. Miller asked, what happens when you dial 988? So just as a reminder, when you dial 911 in Chesterfield County from a landline or a cell phone number, landlines automatically come to our dispatching center. The cell phone works with the triangulation of cell towers, and Mr. Cowell can probably remember when you're on the perimeter of the county, it depends what towers are pinging it as to what 911 center gets it. But our neighboring jurisdictions, they know exactly what to do and where someone's calling from. So we work hand in glove with that. The 988 technology is not up to the same par, GIS nor triangulation of cell towers. So if you're calling 988 from a landline within Chesterfield County, by default you have an 804 area code. If you have an 804 cell phone number, you also are going to be reaching the regional 804 call center. If you are calling from a non-804 cell phone, which many people who have migrated to Chesterfield County have, you are going to get that particular 988 regional center if there's one been created, and if you're not, you're going to get the national center. So we're going to have to work and pay attention to our citizens in crisis who call 988 and hopefully hold the national center or these other regional centers to some accountability, as well as hold our own, because we may be getting calls from an 804 number for someone who's 2,000 miles away. So that's to be determined, but I just want to be clear that when someone who does not have an area code of 804, we would love to emulate the same triangulation that the cell towers emulate, but that we're not in charge of that technology nor process.
And that's the beauty of the call centers in Virginia, and I know it could be outside of Virginia too, but all being operated by the same company that operates the National Suicide Hotline, because they're all operating under the same protocols, they're doing the same assessments. And again, they have told us that the majority of the calls do not involve needing to go out and assist somebody. But if they do, they're gathering that information and getting it to the nearest 911, so you're correct.
Any other questions? Thank you very much.
Thank you.